Okay, so today we're going to discuss cardiovascular calcifications. So we'll start with this case, and we notice that there are linear calcifications here overlying the cardiac shadow, and what this represents is pericardial calcification, as we can see here on the CT scan. Calcification here right along the pericardium, anterior to the right ventricle. Here on the short axis view, we can also see these calcifications. And then we also notice there's a dilated coronary sinus here and dilated inferior vena cava. So this is physiologic evidence that this patient most likely has constrictive pericarditis secondary to their calcifications here. Notice also that the interventricular septum is deviated towards the left ventricle. And then here are volume rendered views, giving you a more accurate representation of the extent of those calcifications overlying the right ventricle. So pericardial calcifications are usually secondary to pericarditis. It can be from viral pericarditis, uremic, pyogenic infection. Tuberculosis is a common cause of constrictive pericarditis worldwide. It can also be secondary to trauma, especially surgery. 50 to 70% with pericardial calcification have constrictive pericarditis, and 90% with constrictive pericarditis have pericardial calcification. Sites of calcification, right side and anterior more likely than the left side, AV grooves and diaphragmatic borders also. Sites that are spared, the left atrium because of lack of pericardium overlying the left atrium, and the left ventricle, probably because of motion of the left ventricle, does not allow buildup of calcification. So pericardial calcification can be thin and linear, as in this example here. So this can be associated with viral and uremic pericarditis. This kind of thicker, chunkier calcification is associated with TB pericarditis. Here's the CT on that case of TB pericarditis with these chunky, thick calcifications affecting the pericardium. Here's some unusual shape to these pericardial calcifications here, and we can see that there seems to be a collection here that is calcified, and this is also indenting the anterior border of the right ventricle. Notice also the IVC is dilated, indicating some element of filling disturbance here and constrictive pericarditis. Okay, so here's our next case, and we see this calcification overlying the apex of the left ventricle. So this patient has a cardiac history, as we can see that they've had a median sternotomy. And this, of course, represents myocardial calcification. So calcification of the myocardium is usually secondary to myocardial infarction. It can occur in up to 8% of cases after myocardial infarction. The most common sites are the anterolateral or apical region of the left ventricle. Calcification also can occur within the wall of a true left ventricular aneurysm. So this type of calcification here, curvilinear calcification over the apex of the left ventricle, is very typical of myocardial calcification secondary to myocardial infarction. And here on CT, we can see the myocardial calcification right there over the apex of the ventricle, very nicely demonstrated. So common features of myocardial calcification, usually preceded by a sizable infarct, affects the anterolateral or apical left ventricle, usually secondary to infarct in the LAD distribution, left anterior descending coronary artery distribution. And we can see this calcification in the wall of a true left ventricular aneurysm. Usually it implies a survival greater than 6 years, since it takes time for the calcification to accumulate after myocardial infarction. So it takes a few years after the infarct for the calcification to occur, somewhat more common in males, and most patients have right coronary artery dominance, as that favors longer survival after obstruction of the LAD. Here's another example of myocardial calcification. This is located along the interventricular septum here. Again, this is secondary to an infarct in the distribution of the LAD. Now in this example, we have a normal sized heart. On the lateral view though, we notice calcifications here right in the middle of the heart. These are calcifications of the aortic valve. And if we see calcifications of the aortic valve on the plain film, it always means that there is aortic valvular stenosis. So valvular calcification, radiographic demonstration of cardiac valvular calcification, indicates valvular stenosis as the predominant lesion. That is not true on CT. CT is more sensitive than radiography, so calcification of a valve on CT does not automatically mean that there is stenosis of that valve. The amount of calcification does correlate, though, with the amount of stenosis, whether it is CT or radiography. The most common valves to calcify: the aortic valve, from atherosclerotic degeneration of a tricuspid valve, from a bicuspid aortic valve, or rheumatic heart disease. All of this can cause aortic valve calcification and aortic valvular stenosis. Mitral valve calcification is almost always due to rheumatic heart disease. So calcification of the aortic valve, we can see this in a bicuspid aortic valve. Bicuspid valve is the most common congenital cardiac malformation. One cusp is larger than the other, so the valve does not function properly, resulting in fibrosis, calcification, and stenosis of the valve. So for a bicuspid valve, the average age as the calcifications are first detected are about 28. The calcifications may be nodular, bicuspid, or mushroom. These patients can have somewhat dilated ascending aorta from poststenotic dilatation of the aorta. This is an example of a bicuspid pattern of calcification. Here is a close-up on the X-ray. On the lateral view, you can see calcification along the raphe of a bicuspid aortic valve. That is a bicuspid pattern of calcification. So bicuspid pattern of calcification can be seen, a mushroom pattern of calcification can be seen. Both of these can be associated with bicuspid aortic valve. Nodular calcification can also be seen. Here's some dilatation of the ascending aorta in this case, and left ventricle also is somewhat dilated in this case from aortic valvular stenosis, and here's the aortic valvular calcification. In this example, this is a non-gated CT, but we can see calcification of the aortic valve, and notice the morphology. We can also make the diagnosis of a bicuspid aortic valve here on this non-gated CT, here on this coronal image, again demonstrating calcification of the aortic valve. This patient did demonstrate aortic valvular stenosis on follow-up echocardiography. And then here is a close-up image showing you a bicuspid pattern of aortic valvular calcification here on CT. So calcification of the aortic valve can also occur with rheumatic heart disease, although when the aortic valve is involved with rheumatic heart disease, the mitral valve is usually also involved. There, the average age of calcification of the aortic valve is about 47, and the calcifications may be nodular. Again, we might see dilatation of the ascending aorta, but there may also be signs of rheumatic mitral valve disease, because most of these patients, by the time they get involvement of the aortic valve, usually also have mitral valve disease. So in this example, on the lateral view, we can see calcification of both the aortic valve and the mitral valve. On the frontal view, we can see some calcification here of the mitral valve. The left ventricle and the left atrium are both dilated, a nice double density here behind the right heart border from dilatation of the left atrium. So this patient has rheumatic heart disease leading to mitral valve calcification, but also has rheumatic heart disease affecting the aortic valve, resulting in aortic valvular calcification also. So atherosclerotic degeneration, this is the most common cause of aortic valvular stenosis and aortic valvular calcification. The average age the calcification is seen is somewhat older in this age group. And again, we might have nodular calcification, aortic dilatation from aortic valvular stenosis, and the heart size tends to be normal unless we have left ventricular dilatation secondary to decompensation of the left ventricle, resulting from aortic valvular stenosis. So a tricuspid pattern of calcification, we might see 3 nodular kind of calcifications as we see here on this lateral chest radiograph and in this diagram. And then here on CT, we see these 3 nodular calcifications. That is a tricuspid pattern of aortic valvular calcification. Here's a close-up of the aortic valve showing you again a tricuspid pattern of calcification on this valve. And here's a close-up intraoperative photograph showing you thickening of the aortic valve leaflets, and then these deposits which have calcified there on the aortic valve. So now it turns out that the extent of aortic valvular calcification on CT does correlate with the degree of aortic valvular stenosis. So the heavier the calcification of the aortic valve on CT, the more likely it is, or the the more severe the aortic valvular stenosis tends to be. So if we see aortic valvular calcification, even on a non-gated CT, we probably should recommend follow-up echocardiography to assess the aortic valve. And this study demonstrates that you can actually score the calcification of the aortic valve, just like we score calcifications of the coronary arteries, and the higher the amount of calcium, that tends to correlate with more severe aortic valvular stenosis. So in terms of when we see these calcifications and when the patients become symptomatic, so at bicuspid aortic valve, if the patient has aortic valvular stenosis, they may become symptomatic at about 30 years of age. The calcifications might be seen slightly younger. Rheumatic heart disease, somewhat older age group when they become symptomatic and when we see the calcifications. And then again, the most common cause of aortic valve stenosis and aortic valvular calcification is degeneration, atherosclerotic degeneration of a tricuspid aortic valve. So that is seen in an older age group. Calcification on the chest x-ray, so it's very common to see that in older patients with bicuspid aortic valve and in older patients with degenerative aortic valvular stenosis and calcification of a tricuspid aortic valve, and less likely to see that with rheumatic heart disease. In this example, we notice that there's dilatation of the main and the left pulmonary artery. The right pulmonary artery is normal in caliber. So this is the configuration of pulmonary valvular stenosis. Notice also, though, that there's calcification of the pulmonic valve. So just like calcification of the aortic valve can be associated with aortic valvular stenosis, calcification of the pulmonic valve may also be associated with pulmonic valvular stenosis. Okay, so what is calcified here? We see this fleck of calcium here between the left atrium and the left ventricle. Here we are at the level of the mitral valve. So this represents mitral valve calcification. When you give contrast looking at soft tissue windows, this calcification of the mitral valve might be obscured, and this is where wide windows can be helpful. These vascular windows with a width of 100 and with a width of 800 and level of 100, we can see these calcifications now much clearer against the background contrast. Here's a short axis view confirming that these calcifications are right in the region of the mitral valve. And so mitral valve calcification can be associated with rheumatic heart disease. So the most common cause of mitral valve calcification is rheumatic heart disease. On the chest radiograph, this may be nodular or amorphous calcifications. It is actually quite unusual to see calcification of the mitral valve on chest radiograph as opposed to calcification of the aortic valve. But other clues on the chest radiograph of mitral valve disease would be enlargement of the left atrium, especially enlargement of the left atrial appendage, cephalization, interstitial edema, and later on signs of pulmonary hypertension and large central pulmonary arteries as a complication of long-standing rheumatic mitral valve stenosis. So here on this chest radiograph, we see calcification in the region of the mitral valve. This patient also has some enlargement of the main pulmonary artery, some enlargement of the left atrial appendage. You can see here on the lateral view how the enlargement of the left atrium pushes back on the esophagus. So this patient has rheumatic heart disease with mitral stenosis and calcification of the mitral valve. This patient has calcification here of both the aortic valve and the mitral valve. The left atrium and the left ventricle are dilated. So this was a patient with rheumatic heart disease who had mitral stenosis and aortic valvular stenosis. When the aortic valve is involved in patients with rheumatic heart disease, most of those patients also have involvement of the mitral valve. And then some more reformatted views in that same patient showing you the calcification of the aortic valve. This patient did have aortic valvular stenosis confirmed on echocardiography. And then here is our calcification of the mitral valve. Now, what is calcified in this case? Here we're a little bit below the level of the mitral valve, here and here. This represents calcification of the mitral valve annulus. This is not calcification of the valve itself, but the fibrous ring on which the valve is inserted. So this can give you this reverse C-shaped calcification on a radiographic examination. Here's a short axis view through the mitral valve annulus showing you that C-shaped calcification of the fibrous ring. So this is not the valve itself, but the insertion, the fibrous insertion of the valve there that becomes calcified. And so on radiography, we can see this as an O-shaped or C-shaped, reverse C-shaped calcification on chest radiograph. And this type of calcification occurs from degeneration due to aging. You might see it in females greater than 65 years of age. Usually only involves the annulus, may involve just the posterior leaflet in some cases. Not clinically important, but massive calcification can result in mitral insufficiency, atrial fibrillation, or conduction defects. So those can be complications of massive calcification of the mitral valve annulus. So on CT, we will see the calcification below the level of the mitral valve, and on radiography, O-shaped or reverse C-shaped calcification as demonstrated there. Okay, so here on this black blood imaging, we have this dark area here, and this corresponds to the region of the mitral valve annulus. Here's that calcification there in the region of the mitral valve annulus, but there's this larger mass-like structure there. So here we have some more CT images showing you that this is located within the annulus here, and does have some low attenuation there, just like fat, some low attenuation within that region. So what this represents is caseous degeneration of the mitral annulus. This can give you a spherical mass-like lesion with calcification. May also have regions of lower attenuation as seen here, similar to fat because of liquefaction necrosis within that. This comes up usually on echocardiography. This looks like a mass, and so they will send the patient to imaging to see what the mass represents in this region related to the mitral valve. So it's a mixture of cholesterol, calcium, and fatty acids yielding a pasty acellular texture. There's a core of liquefaction necrosis, and so we may have this kind of round mass-like lesion with calcification within the mitral valve annulus, and it may have regions of lower attenuation resembling fat as a result of that liquefaction necrosis. Okay, now in this lateral chest radiograph, we see this curvilinear calcification. So what is calcified here? Well, this is calcification of the left atrial wall. And calcification of the left atrial wall is associated with rheumatic heart disease and also associated with atrial fibrillation in those patients. So it's usually secondary to endocarditis from rheumatic heart disease. It's associated with CHF, mitral valve stenosis, atrial fibrillation. These patients can also develop mural thrombi, which puts them at risk of systemic and pulmonary embolism. So these patients may have CHF and atrial fibrillation. The mural thrombi can be dislodged during surgery, resulting in cerebral emboli. There might also be uncontrollable hemorrhage when the left atrium is entered during cardiac surgery, because the wall of the left atrium tends to be very stiff, and it might be difficult to control the bleeding in these cases. So here's an example where there is a replacement of the mitral valve in this patient. There's enlargement of the left atrium, and we can see calcification here within the left atrial wall. So this was a patient with rheumatic heart disease who had developed calcification of the left atrial wall. Calcification of the aorta itself, commonly associated with atherosclerosis, usually the arch and distal aorta. The ascending aorta is usually spared. We can't see calcification in younger patients associated with hyperlipidemia and diabetes. We might get extensive calcification of the thoracic aorta with syphilitic aortitis. That's an inflammatory disease affecting the ascending aorta. It can extend down to the sinuses of Valsalva and to the aortic valve. So these patients might have linear calcification of the ascending aorta as demonstrated here. These patients can also have aneurysms of the ascending aorta, and that dilatation of the ascending aorta can dilate the aortic annulus, resulting in aortic valve regurgitation. On this close-up, we see enlargement of the central pulmonary arteries. There's curvilinear calcification here of the left pulmonary artery. Here we can see on the CT calcification of the right pulmonary artery. And there is no differential for pulmonary artery calcification, so almost always this is associated with long-standing pulmonary hypertension. So calcification of the pulmonary artery usually indicates long-standing pulmonary arterial hypertension if we see it. So what is this linear calcification here in this example? Well, this represents calcification of the ligamentum arteriosum. So this is this linear or fleck of calcification here between the descending thoracic aorta and the left pulmonary artery. So the ductus arteriosus closes, becomes the ligamentum arteriosum, and it is very common to see calcification of the ligamentum arteriosum in adult patients. Here's a very nice example on this sagittal oblique view. You see the linear ligamentum arteriosum extending from the proximal descending thoracic aorta to the pulmonary artery, and you can see the calcification there within the ligamentum arteriosum. So calcification of the ligamentum arteriosum indicates a closed ductus. More examples, calcification here of the ligamentum arteriosum, very common finding if you look for it. Actually, it's this linear calcification right here. That is the calcification there of the ligamentum arteriosum. And as I've said, it's a very common finding if we look for it on CT. Now, in this example, this patient has very large central pulmonary arteries, a huge central pulmonary artery here. But notice on the close-up, there is also calcification in the aortal pulmonary window, extending from the aorta to the pulmonary artery. And that represents calcification of a ductus arteriosus. So in adults, a ductus arteriosus, a patent ductus arteriosus, can also calcify. So here's the patent ductus arteriosus extending from the aorta to this dilated pulmonary artery. So here it is on this sagittal view. Here's the patent ductus arteriosus, which is calcified, extending from the aorta to the pulmonary artery. So here's volume rendered view, nicely demonstrating calcification of the patent ductus arteriosus with a left to right shunt, a huge main pulmonary artery in this case. So if we have dilated pulmonary artery, evidence of a left to right shunt, and we notice calcification in the region of the aortal pulmonary window, then we should think of a patent ductus arteriosus. More examples, big pulmonary artery. Here's calcification of a patent ductus arteriosus here on the sagittal oblique view. You can see the ductus arteriosus there connecting the aorta to the pulmonary artery. And then here on this volume rendered view, we can see the calcification there of the patent ductus arteriosus. Now, coronary artery calcification, this typically occurs especially near the coronary artery triangle, the left upper corner of the heart. Very common location to see coronary artery calcification on the plain film. And if we see coronary artery calcification, it always means, of course, that there's coronary atherosclerosis. So coronary artery calcification indicates atherosclerosis. It's an indication of coronary artery disease. Now, we can measure the amount of coronary artery calcification, and that can be a surrogate measure of the number of soft or vulnerable plaques and the sensitivity and specificity of coronary artery calcification for significant coronary artery disease. Well, I've given you the numbers here. Much of the research early on was done with electron beam CT, so we have a lot of literature with electron beam CT for coronary artery calcification. The absence of calcification on CT can rule out significant coronary artery disease in a large percentage of patients. So early on when coronary imaging was done looking for calcification, it was done with electron beam CT. You needed a fast imaging method, and so in this way, instead of the gantry rotating around the patient, it was the X-ray beam that was rotated around the patient through rotating the electron beam onto the target. And so the X-ray beam itself could be rapidly rotated around the patient. So the early days of cardiac imaging were done with electron beam CT. Now that we have multi-detector CT, this is no longer necessary, as the multi-detector CT scanners are fast enough to do diagnostic coronary artery imaging. Although temporal resolution was always better with electron beam CT than with the conventional CT. Now, what kind of gating is used if we're doing coronary calcium scoring? And so what do we do for coronary calcium scoring? Well, we do a non-contrast CT. We do it with cardiac gating. We identify these areas of coronary calcium, and then we put our regions of interest on them, and then the software will measure the amount of calcium and give us a numerical quantitative measurement of the amount of calcium. The type of gating that is used for coronary artery calcium scoring is prospective cardiac gating. With prospective cardiac gating, we only scan here during diastole, during the diastolic phase of the coronary cycle. We only reconstruct images during the diastolic phase of the coronary cycle, as opposed to retrospective gating, where you can scan throughout the coronary cycle, and since the X-ray beam is on throughout the coronary cycle, you can reconstruct images at any phase of the coronary cycle. Well, retrospective gating does give you a higher dose than prospective gating, so for just coronary calcium scoring, we typically use prospective cardiac gating. So coronary calcium scoring is done with prospective cardiac gating. It's actually quite easy to do. We do this non-contrast focused CT of the heart with prospective gating, and then when we read the study, we just identify the calcifications with the region of interest, and the software pretty much does the rest. Now, the type of calcium score that is most popular, or the scoring system that was most popular for coronary calcium scoring, is the Agatston scoring system. And this is a weighted scoring system, and I've outlined it here for you that about how this is done. It's not so important that you know the actual weighting factors or how it's done. Just realize that this is a weighted scoring system, and it's the sum of the individual lesion scores over the entire heart that determines the total coronary artery calcium score for that particular patient. So this is a weighted scoring system, meaning the higher the attenuation, the higher the weighting for that particular region of for that particular pixel when the scores are added up and totaled. Now, there are other methods of calcium scoring. The problem with the Agatston scores, there's a great deal of variability. If you scan the same patient twice in a row, you might have up to 20% variability in terms of the actual calcium score that you calculate. The volume score, where we convert these regions of interest into volume of calcium in cubic millimeters, is somewhat more reproducible, as is the mass scoring system, where we convert these regions of interest into milligrams of calcium, and all of these are also available within your software, although traditionally the Agatston scoring system is the one that has been used and is still usually used at most centers. So to do the coronary calcium scoring, we identify the regions of calcification along the coronary artery. We put our regions of interest around it. We can also identify which coronary artery we are denoting here. This is calcification along the LAD. This is calcification along the circumflex. And then the software takes all of this into account and then calculates a score for each coronary artery, which it then will total to give you a total calcium score. So here in this example, the software has given us the Agatston score. Here it's 504, the mass score is 73, and the volume score here is 212. Again, it's the Agatston score that is the one that is typically used when you report a coronary artery calcium score, and the one that is used to determine how to manage the particular patient. So in this particular example, these are the ages of the patients. These are the percentile curves. So the red curve is the 90th percentile curve. So our patient is about 61 years old, or between 61 and 65 years of age. So that calcium score of 504 puts her well above the 90th percentile for patients within her age group for the extent of coronary artery calcification. So we report the calcium score itself, and we also indicate a percentile what percent of patients might be expected within that age group to have a higher calcium score. Now, the risk equivalent of these calcium scores, just to give you a general or a rule of thumb here. So calcium score, Agatston score of 1 to 100, usually low risk, and here's your 10-year event rate. Intermediate score 100 to 400, high risk greater than 400, so the 10-year event rate there is greater than 25% and greater than 1,000, very high risk and a very high event rate. So let's talk a little bit about the calcium score itself, and a lot of this makes sense. The calcium score does correlate with the extent of atherosclerosis, but the calcium is only about 20% of the total plaque volume. The rest of the plaque is not calcified. The severity of disease, whether there are obstructive lesions, hemodynamically significant obstructive lesions present, correlates with the calcium score as well as the number of vessels with coronary calcium. A calcium score of 0 might exclude coronary artery disease with a high accuracy in symptomatic patients. That was the thinking early on, although that has become a little bit more controversial, and we will discuss that in a little bit more detail in a few minutes. The sensitivity when obstructive disease is present is about 95%, meaning a calcium score greater than 0. So a negative CT for calcium scoring means the calcium score is 0. Any number greater than 0, 1, or any number greater than 0 is considered a positive CT scan for coronary calcium. And the risk of a coronary event is significantly higher in patients with a high calcium score. Now, the significance of a negative CT for coronary calcium, meaning a calcium score of 0. So 0 calcium means that significant coronary artery disease is highly unlikely, so this has a high negative predictive value. A negative CT, a calcium score of 0, is highly unlikely if there is significant coronary artery disease, so that gives you high sensitivity. Negative CTs, calcium score of 0, will occur in a majority of patients who have angiographically normal coronary arteries who have no coronary atherosclerosis. And negative CT is consistent with a low risk of a cardiovascular event over the next 2 to 5 years. Now, the significance of a positive coronary calcium CT, meaning any calcium score greater than 0. Positive CT means there is coronary atherosclerotic plaque. The greater the amount of calcium, the greater the likelihood of occlusive coronary artery disease, but there is not a one-to-one relationship. The calcium is a marker for disease. It does not mean that the area where you have the most calcification correlates with the region of the stenosis. So this is not site-specific. The total amount of calcium correlates best with the total amount of atherosclerotic plaque, although, as we've said, the true plaque burden is underestimated, as calcium only makes up about 20% of the plaque volume. A high calcium score means that there is moderate to high risk of a cardiovascular event within the next 2 to 5 years, and it is a stronger independent predictor than all other conventional risk factors. And so here's an idea of the survival curves in these patients with calcium scores. You can see calcium score of 0. These patients do very well, and as this calcium score increases, you can see how quickly the survival drops off. Calcium score of 1,000 has a very high event rate over the course of the next 10 years. So the calcium score can be a predictor of the event rate for the particular population of patients. Remember, the calcium is the tip of the iceberg. The calcium is only 20% of the plaque volume. We only see the calcified plaque, but the rest of there's a lot of uncalcified plaque that is also going to be there if we see calcified plaque. So calcified plaque also tends to occur late in the course in the natural history of coronary artery disease. So in patients who have angina These patients might have severe stenosis with calcified plaque, as demonstrated here. The problem is early in the natural history of coronary artery disease, patients can have lipid-filled plaque within the wall of the vessel without causing much stenosis. So these patients can be asymptomatic, and so it is rupture. This plaque is also vulnerable to rupture because of the high lipid content. So this is where a patient can present with myocardial infarction as their first sign of coronary artery disease. So non-calcified plaque, which you can only see with a coronary CT angiogram, this non-calcified plaque is usually the culprit when we're dealing with myocardial infarctions. So what is the bad news for coronary calcium scoring? Well, at age 65 for men and 75 for women, the prevalence of coronary artery calcium is greater than 90%. So the specificity then of coronary calcium scoring for predicting significant coronary artery disease or obstructive disease decreases with age. There's suboptimal reproducibility of the coronary calcium score, as we've said, especially with the Agatston scoring system. And there may be a lack of standardized threshold criteria for significant coronary artery disease based on the age and gender. And so in older asymptomatic individuals, the utility of coronary artery calcium screening is somewhat uncertain for these reasons. Now, this was a large histopathologic study of coronary arteries to examine the relationship between coronary calcium and the amount of plaque and lumen stenosis. This was an autopsy study in a large number of patients here. And what they found was that the amount of plaque and calcium increases with age, as we would expect, that the calcium area and the coronary artery atherosclerotic plaque are correlated. The more calcium you have, the more atherosclerotic plaque there will be. No calcium correlates with low plaque burden or minimal luminal narrowing, as we would expect, but the absence of any coronary artery calcification does not exclude the presence of atherosclerotic plaque. So patients can still have soft plaques even though they have no coronary artery calcification. And there was no correlation between the calcium area and the lumen area, meaning that you can have heavily calcified coronary arteries without causing significant stenosis, mostly due to the remodeling phenomenon, which we will discuss next. So what happens is when we develop calcification of coronary vessels and atherosclerosis, often that calcification and atherosclerosis grows away from the lumen of the vessel. This is called positive remodeling, and so you can have a heavily calcified coronary artery here without much in the way of stenosis of that particular vessel, as opposed to a negative remodeling where you do get significant stenosis of the vessel from the atherosclerotic plaque impinging on the vessel lumen. So coronary calcification is an indicator of overall atherosclerotic burden, but it does not correlate with site-specific stenosis. So that is a very important point. Also, in patients with the first myocardial infarction, 22% of the culprit arteries had no calcification, while 41% had only mild calcification. So it's these non-calcified plaques, these vulnerable plaques, that are the ones that are responsible for a great deal of myocardial infarcts in patients who otherwise had no symptoms of coronary artery disease until their myocardial infarction. Now, in terms of stratifying risk, there is the Framingham risk model where these are available online, these online calculators. This is what an insurance company uses to determine your life insurance premium. You can plug in the age, blood pressure, cholesterol, HDL, smoking, glucose, and it will give you a 10-year risk of myocardial infarction or coronary death. So low risk is considered less than 10% over 10 years, medium risk 10 to 20%, high risk greater than 20%. Now, because of all the studies that have been done with coronary artery scoring with CT, there's the multi-ethnic study of atherosclerosis. These calculators are also available online where you can plug in all of the conventional risk factors, and you can plug in a coronary artery calcium score here, and that will give you a more accurate estimate of the 10-year risk of a cardiac event. And so in this particular example, if we take the same conventional risk factors and all we do here is we play around with the coronary calcium score. So in this particular example, the estimated 10-year risk for a person with this risk factor, the estimated 10-year risk for a cardiac event with this risk factor profile, if you did not factor in their coronary calcium score, would be 12.7%, as opposed to putting in the calcium score of 0. Now that significantly lowers the 10-year risk to 3.5%. So the coronary calcium scoring is a good way of stratifying risk, especially in patients who have intermediate or low risk. So a calcium score of 0 can change therapy, especially in patients who are borderline in terms of their risk factors, in terms of their traditional risk factors. Those patients who have a calcium score of 0, statin therapy is not recommended in those patients. If the calcium score is greater than 0, then statin therapy can be recommended. Same thing is true for intermediate risk. If we have intermediate risk patients here, if they have a calcium score of 0, then statin therapy is not recommended in those patients, and it is recommended in those who have a non-zero calcium score. So the calcium score allows you to re-stratify risk, especially in patients who are at intermediate risk based on conventional risk factors. So if after quantitative risk assessment a treatment decision is uncertain, you can consider calcium scoring. Patients with an intermediate risk based on traditional risk factors, calcium score of greater than 400 will raise the patient to high risk, which would justify lifestyle modification and drug therapy. Also, for diabetic patients greater than 40 years of age, you may also consider coronary calcium scoring for stratifying risk. Calcium scoring may not be reasonable if we're dealing with low-risk patients. You might do it in young patients who have a family history of premature coronary artery disease. So the use of calcium scoring here is to stratify risk in asymptomatic patients. So again, reminding you about the risk equivalence here in the calcium score. So 100 to 400 is intermediate, greater than 400 is high, greater than 1,000 is very high risk if we're going on based on the calcium score. Now, here also we can coordinate this with the MESA studies for coronary artery calcium scoring. And here when we look at the percentiles for coronary calcium scoring, so a score of 1 to 100 or less than the 75th percentile for that particular patient demographic group gives you a low risk of future coronary events. 100 to 400 increased risk of future coronary events, and here you might consider reclassifying the individual to the high risk category, especially if they're in that 76th to 90th percentile, and greater than 90th percentile here, that increases the probability of a cardiac event, so that puts them in a higher risk group. Now, so far we've been discussing coronary artery calcium scoring in asymptomatic individuals. How reliable is a calcium score of 0 in symptomatic individuals? In this large study of 5,128 symptomatic individuals with a calcium score of 0, they found that about 3.5% had greater than 50% stenosis, 1.4% had greater than 70% stenosis. So in patients who are symptomatic, there is albeit a low percentage, but there can be a low percentage of patients here with a calcium score of 0 that can have significant coronary artery disease. So a calcium score of 0 in symptomatic patients does not guarantee that the patient does not have significant coronary artery disease. Now, if we compare calcium scoring with coronary CTA. We see that really when we're looking at the coronary arteries directly, visualizing directly, the sensitivity, specificity, positive predictive value, negative predictive value, certainly far superior with coronary CTA. But the difference is that coronary CTA is reserved for symptomatic patients, and coronary calcium scoring should be done to stratify risk in asymptomatic patients. So that is an important distinction. So the bottom line is, if after quantitative assessment of risk, a treatment decision is uncertain, consider calcium scoring CT. We use calcium scoring for risk stratification in asymptomatic patients, not for detection of obstructive coronary artery disease. And so that concludes this talk on cardiovascular calcification. I thank you for your attention, and we'll see you next time.